Our next speaker is Dr. Sathyan, who is Parthasarathi, who is the chairman of the Sathyan Eye Care Center at Coimbatore. And he's going to deal on something very important, primary angle closure disease, the preferred practice patterns.
Thank you so much. I'm just going to use the American Academy of Ophthalmology preferred practice pattern. I'm not added anything or deleted anything from that. So it is easy for you to just go with this. So understanding primary angle closure disease is essential for our routine clinical practice. The disease has multiple presentations. So it has to be classified like primary angle closure suspect, primary angle closure glaucoma, acute angle closure crisis, then plateau iris configuration and syndrome. Just to understand these three main clinical path. So primary angle closure or whatever the angle closure suspect or angle closure glaucoma, all the three has the iridotrabecular contact that is more than 180 degrees. And if you just look at the intraocular pressure levels, the PACS will be normal and all the other two will have a higher intraocular pressure levels. If you look at the optic nerve damage, only the angle closure glaucoma will have an optic nerve damage. Other two will not have a optic nerve damage. So that's critical. Understanding on the acute angle closure crisis, we all know that the patient is very symptomatic with the high intraocular pressures. With all the other ocular signs, we can elicit in the slit lamp. Coming to the plateau iris configuration, it is nothing but narrow angles due to the anteriorly positioned ciliary body with a deep central anterior chamber. That's very important to understand. Same with the iris syndrome, plateau iris syndrome, but only thing is the iridotrabecular contact is present even after the peripheral iridotomy, and also the IOP is high in the plateau iris syndrome. We have to understand that when we are managing the patient, the care process, especially when we consider the patient, then it goes in the three different ways. One is the preservation of the visual function, maintenance of the quality of life, and we are looking at how we can reduce the risk of acute angle closure crisis. So management of primary angle closure suspect is, we all think that doing, we all want to do the RPA for every given patient, but it is not justified. The risk of developing to primary angle closure is only 4% and much lesser in case of primary angle closure glaucoma. So where do you really consider the RPA in these patients is when there is a real need for a frequent dilatation, then there is a poor access to the healthcare and follow-up symptoms suggesting that there is a prior intermittent acute angle closure crisis. Then some of the patients may require a systemic medications that may provoke the pupillary block. These are the cases where you want to do the RPI. And if you have not done, what you need to do is you have to inform the patient about the possibility of angle closure crisis. So check on their medications which can potentially cause the pupillary dilatation and explain them about what is where they have to go immediately for their acute angle closure crisis. Coming to the angle closure and angle closure glaucoma, all patients requires a PI, but there is a controversial role of a PI in patients with extensive peripheral anterior synechial formation. It is understandable. Just we have to treat these patients as like a primary open-angle glaucoma preferred practice pattern once you have done the peripheral iridotomy. Doing the peripheral iridotomy, it's always better to put the patient on the sympathomimetics, parasympathomimetics, that is the pilocarpine, and constrict the pupil very well so that it is stretched and you can easily do the peripheral iridotomy. So identifying the patent PA is critical. So you have to see the air bubbles and you can see the gush of aqueous and also the pigment release. This is the end point. And you have to make sure that at least 100 microns, that adequate size is there. And we have to make sure again, there is how much of the peripheral anterior synechia is present in the gonadoscopy, whether you do it immediately or a little later on the follow-up also you can do. But IOP measurements needs to be checked at the end of half an hour to 2 hours to make sure that there is no acute spikes in the intraocular pressures. Post-laser medication, you have to give the prednisolone acetate. Some people give 5 days, some people give 10 days in a tapering dosage, but each one can decide on their own way. Looking at the RPA, again, the follow-up, you can do it in days or weeks, but you have to make sure that the visualization of the zonules and anterior lens capsule or the ciliary process to make sure that you have done a proper PI. Opening is good, and you have to measure the intraocular pressures. If the PI is Sorry, if the persistent IOP is there, high IOP is there, you have to understand there is a trabecular damage or occluded PI, or there is a other mechanisms are involved, or patient may have even a primary open angle glaucoma also. Looking at the acute angle closure crisis, you have to give all the topical anti-glaucoma medications, topical, oral, or intravenous. Make sure that you break the pupillary block mechanism, either by corneal indentation or by using the muscle hook. Sometimes you have to go for a surgical PI, but if you are still not comfortable in doing the surgical PI, you can use the hyperosmotics or paracentesis to make the cornea clear, and then you can do the PI. Later on, you can do either a trabeculectomy or just a lens extraction you can plan. Fellow eye, you have to make sure that you do the York peripheral iodotomy, because within a 5 years period, the patients may go in for an acute angle closure crisis in the other eye. PACD and acute angle closure glaucoma, the Eagle study and other study has shown that the clear lens extraction may have a role to play, but I'm not going to discuss that in detail here. The Plateau iris syndrome and the configuration, York peripheral iodotomy may not be very useful. There is no evidence to suggest that. So you have to understand that. But if you have the higher IOP, you just go with the primary open angle glaucoma preferred practice pattern treatment. So other factors to consider, counsel and refer at the correct timings. And we have to make sure that socioeconomic considerations and the quality of life is in our mind all the time. Thank you so much for your attention.
Thank you very much. While Dr. Harsh Kumar is sharing his screen, I have a question for you. In the angle closure disease, the IOP control is not so optimal, and you feel you have to do a trab at this point of time. Would you consider taking the cataract out, even if it is a clear lens or an early cataract? Would you consider that, keeping in mind that the challenges post when you have to do a cataract surgery later? What are your thoughts? Dr. Sathyan?
So having said the clear lens extraction, I think we have one more session on Sunday, but the Eagle study has shown that there is a significant reduction in the number of medications usage.
So I'm not meaning that. You are going to do a trap. Would you like to, in a narrow angle eye, would you like to combine it with the lens extraction, keeping in mind that later the AC is shallow and the cataract surgery is going to be more challenging in these eyes?
That depends upon the intraocular pressure levels also. If the high intraocular pressure levels, then I won't go for lens extraction at the same time, because there is going to be a huge risk of choroidals, hemorrhagic choroidals. So even doing a trab immediately is not going to be a good advice, but you have to just wait for some time, and then you plan whether you want to do only cataract or trab. You can plan it a little later.